Alright, welcome to Rotator Cuff Muscles NMT routine. First thing you want to do is identify where we're going to be, which is starting with the spine of the scapula, bony landmark. Make sure you can find that. Once you've found the spine of the scapula, we're going to be treating the muscles above and below it. There's the spine of the scapula going out to the acromion process, and then here along the medial border of the scapula. If we continue up, anterior to the trapezius, you'll find the superior angle of the scapula right there, coming around and back down to the acromion. And within this area, right here, is supraspinatus. We start out all of our NMT just by some nice myofascial stretching of the overlying connective tissue. Hold each position for a minute. Allow the collagen and the thixotropic effect to take place. You'll do that over the entire region. Okay, do all your dry work first, and then begin with the next step, which is doing some deep stripping effleurage to the supraspinatus. You're going to stand at the head of the table, get into a nice natural stance. Again, find that spine of scapula and roll superiorly, and then just use the spine of the scapula as a rail for your thumb to follow all the way till it reaches the corner, and then lighten up and return. This is deep stripping effleurage to the supraspinatus. This muscle helps to stabilize the scapula and is the most commonly involved tendon tear in a rotator cuff injury. Due to the fact that it runs underneath the acromion and then attaches to the greater tubercle of the humerus, and when the bursa becomes compromised, then you can get a friction of bone acromion onto the supraspinatus tendon, and that can cause some micro tears. This muscle is commonly overloaded when a client overuses these muscles in carrying luggage or using a wheelbarrow or heavy book bags at the side of their arm. The pain for this muscle is going to be located into the anterior deltoid. Trigger points refer commonly there, and it is the most common source of a deep anterior deltoid ache. We're going to treat this muscle 6 to 10 times with some nice, slow, deep stripping effleurage. The next muscle to treat is the infraspinatus. The infraspinatus is located, as its name gives us a clue to, infraspinatus, below the spine. Here's the borders, here's the borders of the scapula. Okay. So this muscle runs pretty much in this entire fossa here. Right along here, you'll see a little bit of teres major, and then deep in here is going to be teres minor. So for right now, we're going to focus on the infraspinatus muscle, again with some deep stripping effleurage in the direction of the muscle fibers. I'm standing cross body, which is an okay technique, mainly for the camera. You can also stand on that side and with an open fist do some nice movements. Start just below the spine of the scapula and at the medial border and begin your strokes. This muscle goes all the way up and attaches also to the greater tubercle just below the supraspinatus tendon. If you put your arm around your partner, you'll find that the tendons run SIT, supra, infra, and teres, about where your fingers lay. Infraspinatus is also painful in its trigger point referral to the deltoid. But unlike supraspinatus, that limits a client's arm abduction beyond 90 degrees, this muscle limits movement of the arm back to the opposite shoulder blade. For example, a client's complaint would be they're unable to reach back and unhook their bra, would be a common symptom of infraspinatus. Reaching back and behind in your car can overload this muscle. However, it's often overstretched due to a tight medial rotator subscapularis. So always look at the antagonist muscle as well. This muscle also has an unusual pain referral along the medial border of the scapula, and therefore should be looked at when anyone comes in with pain in this region. Just move over off these commonly looked at traps and rhomboids and venture off medially into the infraspinatus to see if it may be a culprit in their medial border pain. Once you've thoroughly treated each individual section of infraspinatus with deep stripping effleurage, you'll then want to come back in with fingers or elbow and isolate. You can see John's, I'm at the edge of his infraspinatus. Right there. Okay, roll off of it and there's a distinct dip, and then I've got Terry's minor and major. So on our demo today, it's very easy to distinguish infra and minor right there. You can also have your client do active resistance contraction and it'll show up too. Once you find some hypertonic bands in the infraspinatus, just go in with trigger point pressure release. Communicate with your client to mild discomfort. Will you let us know when you feel mild discomfort? Are we there yet?
You can go deeper.
Are we there yet? Just say when.
When?
Okay, you can see that this is a pretty good amount of pressure, and I would be using my elbow standing on the ipsilateral side. And just let me know when it feels better by saying so. Ooh, very nice. Did you feel that? Yeah, definitely. Felt that release, and so did he. Okay, and I'm just going to friction at this level of release 3 to 9 times, linear friction, and come on out. And repeat as needed throughout the muscle. Go back and reassess, retreat anything else. Infraspinatus has a little brother, teres minor. It's located just adjacent to it. Many of the fibers are located underneath the posterior deltoid. So you want to come off to the axillary border of the scapula, strum across these fibers, and press right into the pocket. This muscle commonly doesn't really have a lot of complaints of its own. It's usually a secondary muscle when infraspinatus trigger points develop. This one will start to develop them as well, called secondary trigger points. This muscle's pain commonly is local. It's just right here, about the size of a silver dollar. Deep local posterior deltoid pain. And no restricted movement. Mostly just come in here, identify it, and then start to do trigger point pressure release communication. Are we there yet? Mild discomfort. Right there? Okay. And just let me know what feels better. Alright, great. Friction at that level of release 3 to 9 times, 4, 5, 6. and come on out. Okay? Deep stripping effleurage and trigger point pressure release to these three muscles. Roll off the acromion process with the client's arm at the side of their body. Gently traction the arm down in depression and create a little space in here, and starting at the top of the acromion, just compress and friction all along the attachment site of these tendons. Hold compression for 8 to 20 seconds and then friction 3 to 9 times. And if you really want to do a friction with good intent, you may want to consider linear friction to help coax the Golgi tendons to relax. Alright. Slide down, turn over. The last muscle is the subscapularis, and it's commonly involved in frozen shoulder, adhesive capsulitis, tenosynovitis, bursitis, itis. It's a medial rotator of the scapula, very powerful, contributes along with pec major in rounded shoulders. Pain pattern is down the deltoid, arm, skipping the elbow, forearm to the wrist. It may be misdiagnosed as carpal tunnel syndrome. Clients will often have limited mobility, restricted movement, frozen shoulder. To access this muscle, we're going to traction the scapula out, away from the body, protraction, reach in and compress straight into the axillary region, and then straight down. Press against my hand, relax. Activating the medial rotator, I can feel it contract under my fingertips, and right there it is. The lateral border of it is most commonly involved in trigger points, and fortunately for us, it's the most easily accessible. Okay? There's a subscapular nerve here, but it's located more medially and superiorly, and is not of a concern. Just be aware of it. Okay, and again, this is mostly, okay, I'm at mild discomfort. This is mostly just trigger point pressure release. This muscle can also create, because of its power and size, interjoint compression, and over time can deteriorate the bursa of the glenohumeral joint, creating a flip over the supraspinatus tendon as the acromion rolls over it without that protective fluid-filled sac, and starts to degrade the supraspinatus tendon. So while supraspinatus tendon tear is the most common rotator cuff injury, perhaps subscapularis may be the most common culprit of that injury. Commonly involved in overhand throwing, pitching, things of that nature. Okay, poor posture. Okay, go to friction and come on out. Give a passive stretch to the area, and go back in and retreat. And that is the shorthand version of the NMT routine on rotator cuff.